Hello, my name is Dr. Ronit. I am the first author of this paper and an inflammatory bowel disease research registrar here in the United Kingdom. We present outcomes from a carefully collected group of Crohn's disease patients with focal intestinal strictures who have undergone stricture resolution using removable stents. Stricturing is a particular problem in Crohn's disease. We know that a third of Crohn's disease patients will develop a stricture at some point in their lifetimes. If an ileocolonic anastomosis is in place, this rises to around 50%. Despite modern immune suppression and treatment with biologic therapies, these rates have essentially remained unchanged. Now, there are a number of modalities for stricture resolution in Crohn's, with surgery perhaps being the most effective. However, there are a number of concerns with surgery in Crohn's disease. Surgery already accounts for the majority of hospitalization days in the disease and up to 40% of the lifetime costs. Beyond this, there are the directly associated risks with surgery, such as wound breakdown, anastomotic leak, hospital-associated infection, and, in a minority, mortality. All these factors taken together bring to prominence the need for surgery-sparing techniques for stricture resolution in Crohn's disease. Endoscopic balloon dilatation is the current first-line therapy for focal Crohn's disease stricturing of the intestine in Europe, the UK, and beyond. EBD has been widely reported on in this context. A comprehensive meta-analysis in 2016 by Navneethan et al., looking at 1,200 patients in 24 studies, found high degrees of initial clinical success. But in the follow-up period, Crohn's disease patients undergoing EBD for focal stricturing required multiple sessions, and 25% went on to needing surgery in the follow-up period. Now, these meta-analysis findings are very much borne out in clinical practice. Once a patient requires EBD for a single stricture in Crohn's disease, there are often multiple sessions needed over a short period of time. Taking this into account, and recognizing suboptimal outcomes with EBD in our own clinical practice, there was a decision to consider alternative therapies at the Royal Derby Hospital. Reports on removable stent therapy for the resolution of focal Crohn's disease strictures really came to the fore from 2012 onwards. Taking this early evidence base into consideration, it was clear that removable stents could be clinically efficacious and safe. It was also evident that protocols maintaining stents in situ for beyond 28 days were likely to have higher complication and adverse events rates. Taking this early evidence base on board, a decision was made to trial this removable stent approach in a carefully selected group of Crohn's disease patients. The device we have used for all the patients in this series is a particular type of partially covered Hanaro self-expanding metal stent, or SEMS. The stent itself is 80 millimeters in length and has a 40 millimeter covered portion. It is deployed endoscopically with fluoroscopic guidance. Once a stricturing lesion is endoscopically visualized, then through the channel a wire and catheter mechanism is fed forwards, through which the stent deploying can happen. Stent removal occurs with, again, endoscopic visualization of the stent in situ, and an engagement of a lasso which sits upstream at the proximal end of the stent. Once the lasso is engaged, the entire stent inverts and then is removed with endoscopic extubation. We have used the same stent for all our patients in this series. The cases we put forward for this series were very, very carefully chosen. First, we identified symptomatic Crohn's disease patients from our follow-up population. Once stricturing was considered, all patients were identified or assessed with MR enterography. Cases were holistically considered along with endoscopic and imaging findings at an IBD MDT. The MDT at our institution consists of multiple IBD-ologists, IBD-focused surgeons, research fellows, and specialist IBD nurses. We had 3 very strict criteria for putting patients forward for removable stent therapy. First, by MR enterography, all strictures had to be fibrostenotic, resulting in some degree of upstream holdup, and couldn't be associated with local complicating factors such as perforation, fistulation, or chronically active disease. Clinically, patients had to have symptoms attributable to focal stricturing and couldn't be frankly obstructed. And finally, once endoscopically visualized, the stricture could not permit the passage of the endoscope, which was our endoscopic evaluation of whether or not a stricture was in fact critical. Between January 2015 and 2019, 245 cases of Crohn's disease-related stricturing were considered at the IBD-MDT. Of these, 76 were progressed onto surgery, with the commonest indications for surgery being multifocal or long-length stricturing. 39 cases were thought to be appropriate for removable stent therapy, and ultimately 21 patients underwent 23 stenting episodes, with 2 patients requiring reintervention in the follow-up period. The majority of strictures treated with removable SEMs were anastomotic, 19 of 21, with the remaining 2 being de novo and terminal ileal. Of the attempted stent placements, 23 of 24 were successful, and all attempts of stent removal were successful. Patient characteristics in detail and outcome measures are presented in text. The most common symptoms prior to stent therapy were abdominal pain, nausea, and diarrhea. The rates of reporting of these key symptoms dropped to roughly half following stent therapy. 87.5% of patients at follow-up were also in clinical remission by CDAI scoring. And in a binary assessment of whether or not patients had symptomatic benefit or complete symptom resolution following stent therapy, greater than 80% confirmed that they had. 2 patients required reintervention in the follow-up period at 4 and 20 months following initial stent intervention. Very notably, no patient required emergency surgery or surgery for any non-resolving stricturing in our follow-up period. Across all stent episodes, that is insertion, maintenance in situ, and removal, there were 5 adverse events. There were 3 completely asymptomatic passages of the stent. Asymptomatic in the sense that the patient didn't realize that they had passed the stent and were pain-free and symptom-free when this had happened. These 3 patients all went on to have abdominal films to confirm complete stent passage. There were 2 episodes of severe abdominal pain where patients had very significant discomfort with stent in situ. A single patient required early stent removal, which resulted in complete resolution of abdominal symptoms, where the second patient had basic analgesia management of this discomfort and scheduled stent retrieval. There were no episodes of perforation, bleeding, or abdominal collections related to stents, in addition to which there was a complete absence of emergency surgery or in fact any surgery required for non-resolving stricturing. SEMS therapy for the resolution of focal Crohn's disease strictures was found to be clinically efficacious in this series. Stent placement was successful in 23 of 24 cases, conveying a greater than 95% initial technical success rate. Stent retrieval was successful and complication-free in all cases. The durability of outcome is unusual in this series. No patient has required surgery for non-resolving stricturing, and only 2 patients have required reintervention in an extended follow-up period. What is needed to establish the role and position of SEMS therapy in Crohn's disease treatment is a head-to-head trial against endoscopic balloon dilatation. Here in the United Kingdom, COVID has had a dramatic impact on life, the economy, and of course medical research. We hope that following this crisis we can bring you further research output regarding stent therapy in Crohn's disease and the biological impacts of stricture resolution in this context. Thank you.